Upon completion of this module, you should be able to define invasive candidiasis and its risk factors. You should also be able to discuss the pathogenesis of invasive candidiasis and list the suitable diagnostic techniques for it. Additionally, you should be able to explain the most suitable preventive and management approaches for invasive candidiasis. Finally, you should be able to identify drug-resistant strains of Candida species. Here, we will have a quick introduction and the definition of invasive candidiasis. Moreover, we will explain the estimated burden of invasive candidiasis and its epidemiology. In addition, we will identify the risk factors for getting invasive Candida infections. Then we will learn the pathogenesis of Candida species. Also, we will determine the different diagnostic methods for invasive candidiasis. Additionally, we will recognize the ways of invasive candidiasis prevention and treatment. Finally, we will go through the antifungal resistance. Candidiasis is a broad term that refers to cutaneous, mucosal, and deep-seated organ infection caused by fungi of the Candida genus, which can occur at any age and usually occur in the setting of easily identifiable risk factors for infection. Candida species colonization is regarded as a prerequisite for subsequent infection. Because Candida species are considered commensal yeasts that are part of the normal human skin and gut microbiota, and they are detectable in up to 60% of healthy individuals, thus, the invasive disease is usually a consequence of increased or abnormal colonization together with a local or generalized defect in host defenses. Invasive candidiasis is an emerging infection and is widely recognized as a major cause of morbidity and mortality in clinical settings. Invasive candidiasis refers to bloodstream infections with Candida species, that is, candidemia, and deep-seated infections with or without candidemia, such as intraabdominal abscess, peritonitis, or osteomyelitis. At least 15 distinct Candida species can cause human disease, but the majority of invasive infections are caused by 5 pathogens, including Candida albicans, Candida glabrata, Candida tropicalis, Candida parapsilosis, and Candida krusei. Also, in certain parts of the world, a previously rare organism, Candida auris, has emerged as a major pathogen. There is a substantial geographical, center-to-center, and unit-to-unit variability in the prevalence of Candida species. Candida albicans continue to be the most prevalent Candida species causing disease in both adult and pediatric populations, but the past decades have witnessed an increase in diagnoses of non-albicans candidemia in both groups. The second most common species is generally Candida glabrata in the non-outbreak setting. It is generally more common among individuals of greater than 60 years of age and among recipients of solid organ transplants. In developed countries, Candida species have been reported to cause up to 22% of healthcare-associated bloodstream infections. In developing countries, Candida parapsilosis or Candida tropicalis are much more frequently encountered than Candida glabrata. Candida krusei is the least common of the 5 major Candida species, and it is most often found among patients with underlying hematological malignancies who have received antifungal prophylaxis with fluconazole. A very worrisome global trend is the emergence of Candida auris. Prominently causing nosocomial infections, Candida species rates 4th in causing all bloodstream infections and 3rd in bloodstream infections in critically ill patients. Worldwide, Candida species lead to high mortality rates of 15% to 35% in adults and 10% to 15% in neonates. Candidemia also results in mortality of 47% of intensive care unit admitted patients and 30% to 60% of hospitalized patients. Moreover, as a result of these infections, expanded costs in healthcare are incurred, ranging from $35,000 to $68,000 for a single candidemia case in the United States. According to literature from Kenya, the significant agent for hospital infections is considered to be Candida albicans. However, Candida auris has recently been observed frequently in Nairobi, and Candida auris remains unreported and up-to-date in Kenya. Also, the drug resistance pattern of Candida albicans and Candida parapsilosis isolates towards fluconazole was reported in Kenya recently. General risk factors for invasive candidiasis might be intrinsic, such as the colonization with Candida species, or the presence of diabetes mellitus, gastrointestinal perforation, increased age, pancreatitis, sepsis, or a severe illness. Risk factors might also be iatrogenic, such as the need for any type of dialysis, especially hemodialysis, the use of broad-spectrum antibiotics, corticosteroids, and other immunosuppressants, central venous catheter, or left ventricular assist device, or undergoing gastrointestinal surgery or other major surgeries. Other risk factors include a long-term stay in a hospital or intensive care unit or the need for mechanical ventilation and total parenteral nutrition. Additional risk factors in patients with a compromised immune system include intrinsic risk factors such as the presence of graft versus host disease, mucositis, or profound neutropenia. While iatrogenic risk factors include undergoing solid organ transplant or stem cell transplant. When perturbations of mucosal microbiota and/or weakening of host immunity occur, Candida species transitioned from commensalism to opportunism, which is associated with the induction of key virulence factors. Firstly, Candida albicans is able to filament and interchange its morphotypes between unicellular yeast cells and pseudohyphae, and hyphae critically promote invasive disease. Secondly, Candida albicans secretes a variety of factors in the context of invasive infection, including secreted aspartyl proteases and phospholipids that activate the innate immune response but are also important for promoting fungal tissue invasion and organ damage. Thirdly, effective adherence and invasion of Candida species in endothelial and epithelial cells enable their dissemination into the bloodstream. The capacity of Candida species for effective adherence also facilitates biofilm formation on implanted medical devices such as central venous catheters, which represents a major source of long-term candidemia. Finally, the development of anti-Candida species immune responses is mediated by the recognition of extracellular or intracellular pathogen-associated molecular patterns of invading Candida species yeast and hyphae by various families of soluble and membrane-bound pattern recognition receptors. This figure illustrates the pathogenesis of invasive candidiasis. As we have mentioned before, Candida species can be detected on the mucosal surfaces of healthy humans. But when breaches in the intestinal barriers occur, for example, after gastrointestinal surgery, Candida species can disseminate to the abdominal cavity directly and invade the bloodstream or candidemia. Under normal conditions, the fungus behaves as a commensal organism without causing disease. However, in case of an impaired immune response, fungal overgrowth is promoted in the gut and candidemia, which can lead to deep-seated opportunistic infections in various organs and invasive candidiasis. This figure shows the surface and intracellular pattern recognition receptors, the different myeloid phagocytes that express them, and the corresponding Candida species pathogen-associated molecular patterns or ligands that they recognize are shown. Timely diagnosis of invasive candidiasis is key to ensuring a favorable outcome. However, there are no clinical signs or symptoms that specific to invasive candidiasis. Thus, invasive candidiasis should be suspected in patients with known risk factors who have an unexplained fever that is unresponsive to antibacterial treatment. Moreover, diagnosing invasive candidiasis can be challenging. Although classical microbiological methods such as light microscopy and culture in general enable the detection of Candida species, the concomitant presence of bacteria in clinical specimens can outcompete fungal growth. Thus, if invasive candidiasis is suspected, the diagnostic laboratory should be notified to use selective media that contain inhibitors of bacterial growth and additional specific diagnostic options, such as antigen detection and polymerase chain reaction tests. Combinations of different diagnostic options could facilitate earlier and more sensitive diagnoses. The classical diagnostic techniques, including the blood culture, remain the gold standard for diagnosis of invasive candidiasis, but it is an insensitive tool, as it is positive in 21 to 71% of patients with autopsy-proven invasive candidiasis depending on sampling frequency and volume of blood drawn. Non-culture-based techniques such as the polymerase chain reaction-based diagnostic techniques have been rapidly evolving and will markedly affect the diagnostic workup of patients within the next 5 years. By contrast, biomarkers, including Candida species, monon and eta-D-glycan and antimannan antibodies have had a variable and somewhat disappointing performance. Once the diagnosis of invasive candidiasis is confirmed, it is important to establish the susceptibility profile of the identified species. Intrinsic resistance is diagnosed by a correct species identification, whereas identification of acquired resistance of the specific isolate requires correct susceptibility testing and application of clinical breakpoints. The Clinical and Laboratory Standards Institute and the European Committee on Antimicrobial Susceptibility Testing have developed reference standards for antifungal susceptibility testing with associated clinical breakpoints for most common species, compound combinations. A range of commercial susceptibility tests is available, and none is superior across all organisms' antifungal combinations. The most common are agar diffusion tests.